My name is Neil Kay. I'm a physician at Mayo Clinic. Just a few disclosures. I'm actually originally from Canada. I was born in Winnipeg, Manitoba, Canada. I still curl. I don't play hockey anymore. All right, Canada. I still remember Sidney Crosby scoring the golden goal in the Winter Olympics. Sorry, America. Go Pittsburgh, right. I have been studying chronic lymphocytic leukemia for a long, long time, initially when I had jet black hair, so it's been a while. And I hope that today I can distill for you what I think is going on from, if you will, point A to point Z or Z, in terms of what CLL patients go through in terms of three things: diagnosis, prognosis and counseling, and then a very little bit on therapy, because I also understand that tomorrow you'll hear more about specific therapy, but I will give you my bias on therapeutic approaches, although relatively quickly compared to other parts of this talk. And I would also like to mention that there will be time for lots of questions and answers at the end of my talk, so hopefully I do provide you with some aspects that will be informative, but also if there are questions, please bring them up. So the title of my talk is such: Essentials of CLL Patient Care for Early Stage and Initial Progressive Disease, Not So Much for Relapsed Refractory. So these are the, if you will, learning objectives. I will go over a relatively new entity called monoclonal B-cell lymphocytosis, or MBL, and its relationship to CLL, and the demographics for both entities. The reason I do that is because MBL, as we and others have shown, is the precursor to CLL. The other point that I will bring up, a major point, is to talk about prognostic parameters that predict outcomes for CLL patients. I will also deal a little bit from that standpoint with MBL individuals as well. What would also, I think, is an important aspect of this talk, what is standards of care for early stage non-progressive CLL. What are things that should be going on between the patient and the caregiver, even if there is not progressive CLL? And then, as I said earlier, I'll review some of the therapeutic approaches for upfront progressive CLL. So let me talk about this MBL, or monoclonal B-cell lymphocytosis, and its classification. It turns out that for many individuals, healthy individuals, if you will, with no known disease, that there are circulating populations of clonal B cells that have a phenotype that is a mapping of the membrane that looks just like CLL. The total B cell count is fairly low. It's now it's likely going to be less than 5,000 per microliter. There are no other features of disease. There's no lymph nodes, no spleen, there's no symptoms. There's literally nothing. And to accept that people have these, and about 1% per year will progress to CLL. And like I said, we and others have shown this. It's not controversial anymore. This is the precursor, if you will, to chronic lymphocytic leukemia. So it turns out that there are some variants of CLL, of this MBL. There is a CLL like MBL, which, as I said, and you don't need to remember any of this, there won't be any quiz about this. The phenotype, that is the surface mapping of these cells, of MBL is exactly like CLL. There's an atypical CLL, and it gets back to your question. These atypical CLLs, which don't have quite the same phenotype, can look like lymphoma. There are very low numbers of circulating clonal B cells in the blood. Usually these folks go under a more extensive lymphoma workup with attention to genetics, looking for mantle cell lymphoma, because that can present this way, kind of an odd little sidebar here. And there's actually a CD5 negative or non-CLL MBL, and again, this is a bit of jargon, but they don't have CD5, which is typically seen in CLL, and the kinds of diseases these people may have if they do have disease is an indolent, a very low-grade lymphoma called marginal zone, or leukemic mantle cell, which is not so benign. So let's just talk a little bit about prognosis of high-count MBL. The most important thing, now this high-count MBL, I should point out, are individuals who have these B cells in their blood between 3 and 5,000 per microliter, and that's routinely available by doing a blood test. The single most important outcome for these people is how high the B cell count is. And we have pushed at Mayo Clinic that we need to use this B cell level in diagnostic criteria in terms of what might happen to these individuals. The other point to make is that the prognostic profile for MBL is very similar to that what you might see in early stage CLL like RY0. The predictors for outcome in CLL can predict time to, this TFS is a treatment-free survivorship. That is the time ultimately the time that an individual may go on to develop CLL. And some of these I'm sure you're familiar with. They include some of the prognostic parameters, ZAP70, the IGHV, that's the immunoglobulin variable region gene, FISH status, and CD49D, that's a flow-based parameter. Any of these, and we often do use all of these when we see individuals with MBL when they're between 3 and 5,000 to try and develop some prognostic counseling for patients. I should tell you that this is a big issue right now in North America and is actually in Europe too. Should we even be doing these prognostic parameters in MBL? And the reason I bring this up is it's costly, and only 1% of these individuals will progress to CLL. However, our stance is that we do and should do this. If individuals do show up in our clinic, we do offer this to our patients. We don't make it mandatory. Many individuals do want to know, if I have MBL, what is the risk of me progressing to CLL? I'm sure that's something you can understand, but it is debatable. So there's some other things that I do want to mention. We try not to use the term leukemia. We reduce it quite a bit for these individuals. In fact, there isn't actually a diagnostic code for this entity. We have to call it lymphocytosis of unknown significance. There's actually no way to get around that right now. We believe it's probably good to not use leukemia because obviously individuals don't like hearing that. And there's really minimal impact on life expectancy, but I did want you folks to be aware of this entity. So what do we do for the MBL? We see them initially maybe a couple of times a year on the first year. We do a physical exam and a complete blood count, the CBC, forgive the jargon. We actually get an absolute lymphocyte count as well. And so one clue for us, for the MBL patients, individuals, is that if their total B cell count ramps up quickly in the first year, once we've made that diagnosis, then we get somewhat concerned that they are going on to CLL. And CLL may be requiring therapy. Here's what goes on in other countries, in particularly the United Kingdom. They have a very different approach to this. They actually have an initial eval by a hematologist, and then the symptoms are evaluated by questionnaires that are sent to these individuals. If they need to have CBCs, I love the quaint English. I grew up in Canada. I love the, you don't call it a blood draw, local phlebotomy. With the central hematologist, they review the labs, and actually these folks don't even go to clinic. So I'm just trying to give you an idea of the extent of where our belief is in terms of good medical care. It's a little different in other places, and I wouldn't necessarily say that that's the right way to do this. So just in summary of this opening dialogue on MBL, there is a high count MBL. It appears to be proceeding, actually doesn't appear, it is proceeding overt CLL. The progression to CLL requiring treatment is about 1% per year, and this has been validated not only in our experience but also in the United Kingdom and also in Italy. So this is not really controversial. Actually is, having said all this about progression to CLL, something a bit more worrisome to us. So in work that we've done now and published, it turns out that these individuals with high count actually have what we call a clinical phenotype. The rates of serious infection, and let me define that for you. This is a bacterial infection, like pneumonia or an abscess or sepsis, requiring hospitalization, is greater than the risk of progression to CLL requiring treatment. And more recently, we've shown that these individuals also have an increased risk of other cancers. That is not just skin. It's also colon, lung, kidney. So there is a clinical phenotype to having high-count MBL. I should also mention, I'm not going to get into any great detail here just because of time, but because of this entity of MBL, we've actually taken and reclassified Rh0s. So some Rh0s aren't Rh0s because they don't have lymph nodes, remember? They just have lymphocytosis. And if their counts fall between 3,000 and 5,000, they're no longer CLL. They have MBL. And that's a very different situation. And I think a lot of people don't pay much attention to that. In one study we published, I believe it's now 3 or 4 years ago, we actually reclassified about 40% of our Rh0 to MBL. So it's not an inconsiderable issue, and one that we like to propagandize to our CLL caregivers. Let me just turn for again, getting back to the question about SLL. So this is a Venn diagram showing you the overlap between the three entities that really, you could argue, are all about the same type of B-cell malignancy. So they all have the same clonal B-cell population. If you did flow cytometry, which I know all of you here are probably quite familiar with, which is basically mapping the cell, clonal B-cells will either configure to CLL, MBL, or SLL, and you can see there's a little overlap there where, although we do believe MBL primarily leads to CLL, it can also be associated with SLL. And as I said before, there's no anemia, there's no low platelet count, and these folks are otherwise well. So let's turn now to the second part of my talk. The key questions that I would include here is, what is my prognosis if I present with early stage CLL, that is Rh0 to 1? What would be my expected standard of care over the next several years? And assuming that in this case there's no progression or need for therapy over time. So just a little bit more on the background of CLL. I put a question mark. Is it a disease of elderly men? When I was younger, I sort of went with this definition. Now that I'm in that category, I guess, I'm not so sure I put elderly in there, but so it is predominantly a disease of men. The incidence in the United States is, I'm sure you've heard this before, it's the most common leukemia in North America, and it's also the most common leukemia in Europe, in Northern Europe, anywhere from 15 to 20,000 cases per year. Individuals over 70 represent the predominant population. Males predominate anywhere from 60 to 70%. Unfortunately, there are 5,000 deaths per year. So the median age, I think, is pretty close to 72 years of age. And about 70% of CLL patients are older than 65 at the time of diagnosis. And that's always an important demographic to keep in mind, especially if an individual is going to go to active therapy. But the first therapy is often after the age of 75 years of age. And the median age of death from CLL is around 79. So I think these are important aspects to keep in mind when we're caring for our patients. A little bit more about the genetics of CLL. There is a familial component to CLL, and actually it's of all the leukemias, it has the strongest familial component. There's an 8.5-fold increased relative risk for CLL in first-degree relatives. I don't think it's in these set of slides, but I will throw this out, that if you have CLL, there is an increased chance that one of your first-degree relatives or closely related relatives will also have MBL. And we have family pedigrees, and these are not that common, but we have family pedigrees where there are 2 or more family members that have CLL. The full incidence of MBL is maybe 5 times as great as the otherwise so-called healthy population. Now, one thing that we've focused on at our place is to look at what's called GWAS, which is basically what you're born with, the genes you're born with. It's a complete mapping. It's a genomic-wide mapping. And interestingly, and this is out of date now because of publications that have come out, there's probably 30 different genetic loci. Actually, it's probably closer to 40 that explain a proportion of the familial risk. So there's something about these genes that predisposes individuals to get CLL. It is not, obviously it's complicated, and we don't recommend, by the way, screening family members to have this. We do invite our patients to, if they're interested, to sign a consent and potentially involve themselves and their families in these genetic studies. But we're not at a point where we can truly identify with high reliability what their risk would be. But that's the data we have. So the age distribution of CLL, just a little bit more about that. Interestingly, 30% of patients are under the age of 64. I've actually seen a patient who was 18 years of age. Now, that's obviously terribly unusual. But as I hinted to you, I told you, the dominant percentage of individuals with CLL are over 75. So what is the survivorship at this point in our analysis, ongoing analysis? CLL patient survivorship still is a median of 10 years of survival. The range is, as you know, quite wide. Some very, very low, less than 2 years, more like acute leukemia, and some that are truly indolent. My oldest living patient is 99, and she was diagnosed, I think, at age 55. So tremendous heterogeneity, as you know. What we do also know is that 65 to 70-year-old individuals have a decreased survivorship compared to the otherwise healthy population. And that's quite clear. And this is independent of therapy. For individuals over the age of 75, there's a worse survival, particularly for males. And this has been shown in other countries, in Canada in particular. They've looked very carefully at this, and it appears that males actually do worse with this disease, everything else being equal, compared to females. This is a curve taken from one of our publications where you see the age-matched population, and this initial line here, this higher line here is the age-matched population, and you can see the observed CLL population has a clearly diminished survivorship compared to an otherwise normal cohort.
Dr. Kang?
Yes.
Is it important to note that last slide is dated from 2009, so it doesn't necessarily reflect current or future trends with new treatments?
Again, these are untreated, non-progressive CLL, so it's possible. I did say it's ongoing, and I appreciate that question. It might be modified, but if it's going to be modified, it would have to be because the otherwise untreated population is presenting to us earlier and perhaps has enhanced survivorship. So I'm trying to keep this talk focused on non-treated patients, but I appreciate your question. And I think there are dynamics of the CLL population that unfortunately contribute to other morbidities and mortality issues. So, yes?
I have a question. This is all untreated.
Yes.
Does that imply that their CLL never progressed to a point where you would treat them?
Yes.
And so
yeah.
They just happen to be carrying a low, a minor, what I would call a minor case of CLL, but it still affected their survival.
Yeah, so yes, the major issue we believe is other comorbidities, cardiovascular disease, renal disease, liver disease, or combinations of those. Probably, again, in our analysis, this is Olmsted County, Midwest Minnesota, so the home of Fargo. So we think about 90% of individuals that we see in our clinic have comorbidities. And this is more detailed in this publication, but there may be something about CLL that just makes it worse. We're not sure. Yes.
So were they matched for weight, for example, or health?
They were matched for a lot of variables, a lot of health variables. I can't quote you exact chapter and verse, but it certainly this was looked at in terms of at least the obvious comorbidities. So there was a relative match there. But again, there's something about CLL that seems to make those comorbid features worse. I'll give you a specific example. If a patient with CLL has prostate cancer or breast cancer, that disease tends to be more aggressive than someone who has breast cancer or prostate cancer and doesn't have CLL. And, that's just a repeatedly observed phenomena. It may be related to maybe the CLL is the tip of the iceberg. There's something else going on that modifies their health, their immune system, whatever.
Like with this mortality applied to an obese person who's gained weight as a normal person?
It isn't. We've not compared obese CLL to obese healthy controls. My feeling would be it might be a bit tighter, but it's still different. And this is not just our data. There's also data from other places that have found this. So
Do these statistics apply to SLL?
the question is, does it apply to SLL? I believe it would. For the most part, these are CLL patients, not people who presented initially with SLL. I have to tell you that I believe SLL and CLL are exactly the same disease. So that's my bias.
Do you have patients that are diagnosed with both CLL and SLL?
They come to us, so the question was, do patients have both CLL and SLL? I think it's an unfortunate confusion. SLL to me is CLL with a lot more lymph nodes, and CLL is SLL with a lot more marrow and blood involvement. If that makes sense to you. And at least where we are, we do not differentiate. However, having said that, my lymphoma colleagues will come to me and say, I have a case of SLL. And I'll say, oh, you mean CLL? And they'll say, no, SLL. So it's a debatable controversy. I think they're the same. They respond the same way. The prognosis, we can give them prognostic features, which I'm about to go over, that apply to them equally if they were initially diagnosed with SLL as if they were CLL. So that's my interpretation of that. Good question.
Well, your Venn diagram is a little confusing.
Yeah, it was meant only to, well, I'm sorry about that. I'll delete that from the next. It was meant to clarify. My colleagues have told me that sometimes I do that. It's just that I guess it provoked your question, but really if you look in the literature, there's a clear differentiation, but in our minds, it's not. They're the same.
One other question.
Yes.
You're talking about genetic markers. How about environmental markers?
Yeah. Yeah, I didn't include this. It's a great question. The question was, how about environmental markers? So I work with very closely with wonderful environmental and bioinformatic and epidemiology colleagues. Her name is Susan Slager. For any of you who are interested, Slager. And she has, what typically happens to a patient when they come to see us is we ask them to sign a few consent forms. One of them is to enter into this epidemiologic study where they get a chance to fill out a questionnaire that goes back to when they were as early as they could remember, like when they were 5, 6, 7, 8, 9, whatever you can remember. And it talks about everything. It's a 40-page questionnaire. And some of the highlights they can give you is pesticides, some allergies. These are not high hazard ratios. These are signals. Farming, rural exposures, some other chemicals, body mass index, even height, I believe, has come out. Height. Yeah. I think it may be the only value in being short that I know of. But there are some attributes coming out about environment, but it's not very hardwired. So I don't typically include it in this talk, but we are looking at it. So your point's a good one. I mean, it's genetics plus environment that's going to play a role here. Okay, let's dive pretty deep into prognostic status. Again, this is bringing coals to Newcastle, but most patients are diagnosed with stage 0 disease. And because there is a wide variability in the behavior and aggressiveness, some patients live decades without any treatment, but others develop symptoms and need treatment quickly. So you know this. We use a bunch of tools to come up with prognostic information. I'm going to quickly take you through the history of this prognosis. Of all the things I'm going to tell you today, maybe this is the most important. Because in my lifetime in looking at CLL, this has evolved from being pretty bad. I think pretty bad is a good word, is a good way to pretty good. And I think is helpful. So let's look at the traditional prognostic factors. These were obviously advanced stage, advanced RI, short lymphocyte doubling time where it doubled in less than 6 months or 12 months. If we did bone marrows and saw a diffuse pattern, diffusely involved instead of nodular, that was bad. Male gender, advanced age, and the level of beta-2 microglobulin. These were all pretty powerful, but not that powerful. I'm going to introduce something to you now. How many are statisticians in the audience? Okay, good. I can lie to you. So, C statistic, C for Charlie, C statistic. If it's 0.5, you might as well flip a coin. That's how good the prognostic test is. If it's 1, it's absolutely perfect. I'm going to tell you we're going to get to a prognostic model that's 0.75. Does that make sense? So, but let me go through how we got there, because I think it's worth you knowing this. So for these parameters, this was really a problem. It was often after the fact. That is, these things came up really after people were developing progressive disease. It wasn't years in advance. It wasn't telling us that much. And also, some of these things are complicated by other diseases. Particular beta-2 microglobulin can be up for other reasons, kidney issues, short lymphocyte doubling time because you're infected or have inflammatory diseases. So what about, what was the next major advance? Of course, this was Dr. Rye's major contribution, 1975, was these stages 0 through 4, so 5 different stages. And the characteristics, I'm not going to go over them with you, but you can see vary as with advancing disease to where people have low hemoglobin, low platelet count. And look at them. This is in months. The median survivorship in 1975 was anywhere from 19 months to 150. Okay, so that was in 1975. However, we updated this in 2009. That was just before the era of these BTK BCR inhibitors, and this was a Mayo Clinic population of almost 2,400, and you can see there was an improvement where RY0 was now at 168, but the bigger improvement was in RY3 and 4, where, of course, chemoimmunotherapy, CIT, played a major advance. And my bias, by the way, is that that's still an important approach to consider for certain patients. Just
that's the most current graph that you have is 2009.
Yeah, we've updated this but not published it, but it looks roughly the same. There's a slight improvement in 3 and 4.
But not even with the new medications?
No. But there are reasons probably. You're talking about for the RISE 0 and 1s?
In general, that 168
Yeah.
is at the
Yeah, it's not, well, we can get into that in greater detail. Let's come back to that, because I think that is an important question. I just wanted to clarify a couple of things here. You've heard about the Binet, that's the European classification, so Jacques-Louis Binet and Conti Rai had roughly the same years got together and came up. So Binet's A is actually Rise 0 and 1, just so you're clear about that. And there is some correlation between outcomes, median overall survivorship, but I just wanted you to be aware that, just as an anecdote, I have to tell you that Jacques-Louis Binet and Conti Rai have been friends for decades. But I found out through email, the power of email, that Conti Rai does not understand French. So, rest assured, the research is going on. But it was quite hilarious. I once confronted him. He said, "You didn't know what he was saying?" So my wife, who knew French, was translating for him. Okay, so that's the point. And again, the median overall survivorship, that's the old data that I was giving you for Rise 0 and 1. Now, so let's get into, if you will, more novel prognostic factors. This is the FISH panel, where we go from really a hierarchy where it's good if you have 13Q and it's bad if you have 17P or 11Q. And this is the good old days prior to about 2009. So this, as you know, is changing rapidly. Just a brief description, excuse me, of the immunoglobulin heavy chain variable region, the IGVH. That's one small portion of an immunoglobulin gene where we sequence across the variable region. And if it's close to germline, what you're born with, that is not good. So you're unmutated. I know that sounds counterintuitive, but it's not good if you're unmutated. You're high risk. If you're mutated more than 2% from germline, so just think of it like an alphabet where the A is now a D and the B is now an L. So things are changing. If you're mutated, that's favorable. But that's the way it is. I'm going to mention 38 and ZAP70, but I'm going to tell you we actually don't use these anymore. We use CD49D because we think that's a much more powerful prognostic parameter. But that's what's out in the literature, and a lot of people are using these in clinics, whether it was academia or the community, to measure your prognostic risk. So the worst outcome might be 17P along with an unmutated, non-mutated status. So several years ago, a group of us got together, particularly the German CLL study group and Mayo Clinic, and we started integrating a lot of these molecular biomarkers, and there's way more than, of course, I have time to mention. And they initially pooled these are phase 3 trials, almost 2,000 patients, and did a multivariable and came up with 8 factors that independently associated with survival. And interestingly, Rye stage did not fit into that prognostic parameter. And I'm cutting through a lot of work here, but this is published in Blood a couple years ago. And the hazard ratio means the chance that you would have progression. So these parameters, if you were male, greater than 60, had deletion 11q, performance status was greater than ECOG 0, had this unmutated variable region, high beta 2, a thymidine kinase level, which we don't do in North America, and deletion 17p. And you can see most of the points came out for high beta 2 and deletion 17p. And the way this configured was that if you had 0 to 2 points, so now this is finally a number that we can deal with, your 5-year survivorship was quite good, 95%. And you can see as you garner more points, your 5-year survivorship changes, and that 19%. Remember I showed you that 19% for RY4 comes back. So this at least is a, if you will, biologic way of coming up with a prognostic parameter. And it did involve these 8 parameters. There were issues with it that we don't do thymidine kinase, and 17 FISH wasn't necessarily available everywhere. But I do want to tell you that we actually did some validation at our own place, and what you see here is our figures showing you the very, very, very different clear differences between these 4 risk groups: low, intermediate, high, and very high. And this applied also to the Binet A. But we've subsequently gone on to something further, and this is called the CLL IPI, CLL International Prognostic Index, or CLIPI. And I really like this because this has undergone even more rigor. This is the C statistic 0.75, where you have a much greater power and confidence in telling individuals what the outcome might be. So let me just quickly go over them again. Here's the 17P again. IGHV status, the beta 2, clinical stage. Now, Binet or Rye comes back into this analysis, and age. And this scoring system is now 0 to 10. So you can see you can have anywhere from a 0 to a 10 with CLL. And note again that for 17P, this is fading out on me, Victor, unless you have another pointer. The 17P, you still get the highest number. By the way, that also includes P53. So, how does that look? We think this is better than the prognostic model I just described, and this one has been published just last year in Lancet Oncology. And we actually were so interested in this that we decided to validate this on our own. I think ultimately it was included in the publication. So what you see here are early stage patients, untreated patients, who have the CLIPI applied to them. And again, you see these cohorts, low, intermediate, high, and very high, where the 5-year overall survivorship is very, very different. So we're very enthusiastic about this. The way this translates, again, is you see the scores here. This was just numbers of patients that fit within these in the initial publication, within the 0 to 10. But I want to show you what has come out of that were recommendations from this publication. You may or may not agree with that. But for people who undergo the CLIPI, if their score is 0 to 1, the recommendation is just to watch. For the intermediate, 2 to 3, do not treat unless they're symptomatic. So there is still some nuances here. And for high, 4 to 6, these would be patients who would be treated unless they're asymptomatic, in which case you could still elect to follow the patient. And for very high, these would be clinical trials or treat off trial. So these were recommendations made at the time of this publication. Yes.
So the groups that you chose to treat or to treat, was their survival extended?
Is there?
Survival extended?
We don't know yet, but that's a great question. I don't know if you could hear that. The question, I believe, was, so if you decided to treat in the high, would their survivorship be extended? Our suspicion is we're doing a good thing for them, but we've yet to prove it. This CLIPI has only been out for the last year or two, but your point, I'm glad you raised that question, because we're trying to push that all clinical trials should use the CLIPI in order to validate that it's not only important in predicting where patients may go once they're diagnosed, but what happens on trial. I will share with you some unpublished data if you bring that question up again in the Q&A. Okay, this is what we do at my place. We actually have a form that we fill out for the patient. This is actually a document we use, and it looks at the FISH, the unmutated status, the beta 2, the Rye, and the H, and we explain how you get points for this, depending on what the results of these tests are. And by the way, we do ask that we require that the beta 2 be close to diagnosis and the FISH, because these are two parameters that can change. So that's the one caveat about this. And then they get this, we give them our counseling based on this. A couple of other things I will mention is that we're trying to improve upon this CLIPI. For example, we're now putting in what we think are more powerful prognostic parameters. I mentioned the 49D, and we're trying to get that into the model to see if we can get as close to 1 as possible. Okay, so just a summary of it. Why use prognostic tools? We believe it's very, very important for counseling. A good prognosis can be as important as knowing a bad one. In terms of follow-up, risk of recurrence, we hope that that's actually going to be valuable for treated patients. If there are early intervention trials, if early stage patients have high risk, these would stand as qualifiers for entry into a trial. And potentially treatment selection if patients are progressive. This is particularly important for 17P. It was more important when chemoimmunotherapy was the only option. With these newer drugs, that isn't as important. So let me go through my next phase, which is actually also a relatively major phase of my talk. I want to talk about standard of care, what we believe should be standard of care during the early stage phase. So this is kind of our practice plan. It isn't absolutely fixed in stone. For year one, we like to see patients every 3 to 6 months do a physical exam and a complete blood count. If they have high-risk fish like 17P or P53, we may see them even more often, just because we're concerned about seeing what's going on in that first year. For year 2 and beyond, if they're stable, complete blood count and physical exam now every 6 to 12 months. Intermittent evaluation of kidney and liver function, more because if we were going to put them on chemoimmunotherapy, we wanted to make sure that their liver and kidney functions were okay. And then additional testing as directed by signs and symptoms. If they're having recurrent bacterial infections, we would want to know what their serum immunoglobulin levels were, because we can replace that potentially with intravenous gamma globulin. We also want to rule out autoimmune disease like autoimmune hemolytic anemia or immune thrombocytopenic purpura, low platelet counts, because these are treatable in other ways than treating CLL. And I mentioned follow-up for newly diagnosed MBL earlier. We see them a couple times in the first year, but then less thereafter. What about, I think for now, we can leave that extra one here. Okay, it's working right now. Don't leave. So it's been a bit haphazard. So infections, I do want to spend some time on this. Infections are a major cause of morbidity and mortality, even in untreated patients. So particularly we worry about pneumococcal disease. We do recommend Prevnar and Pneumovax, and I'll give you the approach in more detail in a moment, but it can mediate protection for years. Influenza on a yearly basis is recommended. The influenza infection is actually more likely than pneumococcal if you're exposed to healthcare workers like me. We actually recommend a high-dose flu shot because CLL patients do not respond as well to vaccination. And again, I know you've heard this before, but vaccination responses are suboptimal, and this includes almost everything that you might receive, even if you're early stage untreated. We're trying to work on that, but that's why we like the high-dose flu shot. But we do need clinical trials to augment the immune system in CLL patients, and we can get into that in the Q&A. Do not have a live attenuated vaccine. That's our philosophy. I'll come back to that in a moment. So for the pneumococcal vaccine schedule, if you have not had this before, we recommend PCV13, that's Prevnar, then followed by Prevnar 23. And the interval should be around 2 months. If you've had one of these, either the Prevnar or the 13 or the 23, then you should get the other one, depending on which one you had. But the optimal one is to get Prevnar 13 followed by Prevnar 23. Based on the CDC work, it looks like that gives you the best chance to have the most robust antibody response. How often? Well, we believe right now you could get a second vaccination schedule, but there's no data to suggest that it's going to change things very much. So probably one time would be sufficient. But again, that's a moving target, and we keep working with the CDC to see if they're updating that for other individuals. It may change, but right now it looks like one time. So I do want to mention, I apologize for this busy slide, but I did want to emphasize contraindicated in CLL are any live or attenuated vaccine. That's our stance. This is controversial, but disseminated zoster, shingles, can and has been reported, can occur and has been reported. But you will go to caregivers who won't necessarily go with that. There aren't really a lot of controlled trials to validate it. We're just concerned that that may be an issue. Yes?
Is there any issue with someone, a spouse, for example, having these live vaccines?
That's a good question. I would say that in the initial week or two, there may be some shed virus, so I would be a little bit careful. But again, no controlled clinical trials, but I do think there is a risk. I don't think it's huge, particularly for, I would say, I'd be more concerned about the zoster. If you're going overseas and you need yellow fever and so on, there are infectious disease consultants who can help you more with that, but I'd be a little concerned. So what about other supportive care guidelines? Oops. There should be age-appropriate cancer screening and health maintenance, especially in early stage. I mentioned earlier there is a bump on the radar screen, if you will, for second cancers. And this isn't just skin, although skin, to me, is the most worrisome. Basal, squamous, and even melanoma are increased in incidence in early stage untreated patients as well as more advanced. And this can be problematic. They tend to be more aggressive and can be metastatic. So you want to see a dermatologist at least once a year, every year. What we recommend is, as is laid out here, whole body skin exam. If you go to a dermatologist and they say they don't know what a full skin exam is, leave them. But don't give them my name. And you should stay out of the sun. So for the golfers in the audience, be careful. Yes, please. Yes.
The risk of skin cancers because of age or not because of the disease?
The cancers?
Yes.
We believe it's related to the CLL and to the immunodeficiency that's present. There are, I won't go into great detail, but again, even in untreated CLL, if you will, those B cells are taking up space that would ordinarily be there in a lymph node. And it's not allowing the lymph node to have normal processing and germination of immune functions. That's my calculated guess on that. And we are trying to develop trials that help restore that and prevent it, but it's going to be there even if you're not treated. So what else can you do for yourself in respect to supportive care? We do recommend vitamin D. There is a significant difference in cancer progression and death in patients who had sufficient vitamin D levels compared to those who did not. And we have published this, and so have the Italians. So if a CLL patient presents to us and their vitamin D level was low, they were more likely to progress to therapy, needing therapy, than those who did not. It looks like about a third of patients, for people who live in northern climates, usually you're well clothed in the winter, you do tend to get less sun. And that can be avoided. Just take vitamin D3. It's a modifiable factor. I highly recommend it. Currently, our knee-jerk reflex is to say take vitamin D3, 1,000 international units every day for the rest of your life. Yes?
Would you recommend a hydroxy 25 test, and if so, what would be your optimal number
Yeah.
of comfort, because it's probably different?
It is different. The test. The question is what test would you recommend? Is the 25 hydroxy plasma level over 25 or 30? But the levels vary from place to place, and I've had colleagues of mine call me from Ohio State and MD Anderson because we've published this and tried to publish others, and they believe our levels are not transferable to other centers. So I'm not going to tell you that I know exactly the level, but I'm comfortable with patients having anything over 30 or 40. If there's malabsorption, they may need more vitamin D3, but 1,000 IUs in someone who's healthy and absorbing should be plenty per day. Yes, please.
When you're talking about second cancers, if you're first diagnosed with lymphoma
Yeah.
It comes back to someplace else in the body, but it's not the spleen. Is that considered a second cancer? Or?
It's the same diagnosis. It's just in a different place. Is that what you're saying? It was.
I think so.
So if it was a lymphoma and then it came back.
Like, first I had it in the spleen, and then it came back like in the pubic bone, in the bone.
It sounds like if it's the same disease, it would just be progression of the same disease, just a different organ site. Does that make sense? So. Okay, so just in summary then, before I turn briefly to therapy, early stage disease can truly be a chronic disease still, without progression for many years. The issue of detecting early stage high risk is there now with the CLIPI. Well, at least we feel a little bit more comfortable about doing that, and there are implications for monitoring and potential early stage clinical trials. There are important health aspects to attend to with early stage. Certainly I always recommend to my patients that they stay fit. Just even walking 20 to 30 minutes a day, you'll be doing more than 99% of Americans by just doing that, or Canadians. Skin cancer evaluation is extremely important. Of course, again, getting appropriate screening for men and women is absolutely vital given the slightly increased incidence of other cancers and potentially more aggressive ones. And then the vaccination protocols I talked about. Let me turn to treatment, my last portion of my talk. How are we doing? Are we okay? Okay. So just want you to be aware that I see many patients coming to me who are on treatment, but they don't necessarily fit these guidelines. And everyone should memorize these. I'm talking about my colleagues. Because right now there is nothing better. And these are published in Blood, in international workshops, CLL, that's the IW, and these are criteria. The progressive marrow failure with these values, you don't need to remember them, but the marrow is not working convincingly, or there's huge, by physical exam, not imaging, spleen, that there's progressive or painful, the lymph nodes are clearly getting more and more advanced, or people have fever, night sweats, chills, or particularly weight loss, unintended weight loss. And then these autoimmune cytopenias I referred to, I didn't have a lot of time to talk about these, but there is an increased incidence of hemolytic anemia, red cells being broken down, and then platelets dropping because antibodies are coating these platelets and then they're being taken up by the spleen. So any one of these, the typical one is this, that individuals are starting to become very anemic and have very low platelet counts. This is the usual reason, but there are people who come to me and they're being treated for other reasons, which I don't think should happen. I just want to mention CIT briefly. You're going to hear more about this tomorrow, but the CIT approach has been tested now for 2.5 decades at least. There are several options out there, FCR, fludarabine, cyclophosphamide, and rituximab, or fludarabine, rituximab. We use in particular, actually we don't use a lot of fludarabine if we use it. We use pentostatin, I can get into why later, or bendamustine, rituximab, and obviously these are for progressive patients up front. The reason I emphasize this is there is a group of CLL patients who have two genetic patterns. One is they don't have high-risk FISH, so they have 13q or they're normal, and they're mutated in their IGVH. And if they do prog to requiring therapy, there are 3 studies now that have shown almost a flat line, very good news, where it's out 10 or 12 years. And these folks are not relapsing. And I know there's controversy about using chemoimmunotherapy, but I believe there's some happy news out there too. We can't lose the forest for the trees here. Obviously, for patients who are high risk and have unmutated, they do not do well with CIT. And once they get CIT, you can have very prolonged cytopenias. But again, this subset that can do pretty well. There are alternative regimens for elderly CLL patients. We actually like using, for upfront elderly patients, this regimen here, PCR. There's a reduced myelotoxicity, bone marrow damage, and improved tolerability. We can use it in patients with some kidney disease. And there's also another combination called obinutuzumab plus chlorambucil. highly effective. We use it a lot in our elderly patients and have used it even in patients who are 80 or older. I just want to, this one slide, I think there's a couple here actually on the newer therapies. So this is my quick bias on these, the oral signal inhibitors, idelalisib or ibrutinib, and now more recently venetoclax. So obviously the idelalisib is only been approved for use in relapse refractory RR and should be used in combination with rituximab, but not for upfront CLL because of liver tox. The ibrutinib is approved now for every CLL patient, upfront, high risk, and relapse refractory. The good news here, and you'll hear more about it tomorrow, is 90% overall response rates. Not that many complete responses, but there's some issues. I'll just, and the remissions are extremely durable, even in high risk patients. So that's very good news, but it does come at some cost. There is now a venetoclax, which is a BCL2 inhibitor. It works differently than these, and it's FDA approved for relapse refractory. Problem with this drug is that often you have to be admitted to hospital for this initiating use, and it's not completely perfect. However, it's pretty good. It can work. With all of these inhibitors, still if you unfortunately were to have 17p or p53, there's a higher rate of relapse. Now, at what price new agents? Two considerations. One is their new toxicity profiles. So these are now low grade, maybe 1 or 2 instead of 3 or 4, but consist of rash, problems with inflammatory lung disease, diarrhea, colitis, arthralgias, atrial fibrillation, bleeding, to name a few. So I'm not totally in love with these drugs, as you can tell. Also, they're very, very expensive, and only going up. We all need to speak out about this. Some of my best friends are in pharmaceuticals, but it's just not right. At any rate, you guys know about this. CIT, if you were to progress, is a limited approach where it's still not cheap, but it's less. I think, sorry, this just outlined some of the toxicities that I had mentioned before. They're quoted in most articles as modest, with the most frequent. I just listed them for you. You can read that. I think the most problematic issues for ibrutinib are that patients who are on multiple drugs have a problem with the ibrutinib either being too low a dose or too high a dose, and that's what this means. For patients on ibrutinib, because of the bleeding risk, if they're on anticoagulants like warfarin, can be some major bleeding, and there is a whole. I think if I had $25 for every time a patient called me and said, I'm going to have a dental procedure, what do I do with my ibrutinib? I would be a rich person, because it's a quandary. And especially if they're going to have extractions, I can tell you right now my practice is to hold it if there's going to be some sort of more major dental procedure for 3 days before and 3 days after. But there's no fixed, perfect schedule. If you had to come off a signal inhibitor, they can be explosive with disease recurrence if you can't tolerate them. And venetoclax, I mentioned that you have to admit patients to hospital because of there is a syndrome called tumor lysis, which can be very difficult to deal with. This is my last slide. I just want to acknowledge I couldn't give this talk without the contribution and cooperation of the patients and their family. And particularly, I want to mention my colleagues at Mayo Clinic, who have been a great group to work with and still are. Tim Khalsad, Kandarian, Samir Parikh, Wei Ding, and in particular, Tate Shanafelt. You'll like this story. He is now not with us. He's at Stanford. So his passion was CLL, and out of his passion for CLL, I don't know how many of you remember some of his publications. You probably don't. He's a young guy. To me, he looks like Mark Twain. He's got shocking red hair. He published on wellness in CLL and how people are anxious and need to have counseling often, and it's not a straightforward issue of that you have a leukemia that's not going to progress. Well, he translated that into wellness for physicians and is now a senior associate dean at Stanford. for physician wellness. So we've lost him in CLL, but we got him for our help. So he was an amazing guy and still is. And also I do want to thank the financial support of the NIH and National Cancer Institute. So thank you for your attention. Happy to answer questions.